So, how are governments and the private sector trying to create greater value? I mentioned it was this meeting all day today and 2 other ones earlier this week. Value is the new thing in healthcare. It's changing the world, or people are trying to change the world. In order to give you a perspective on how it's changing the whole paradigm, let me just walk back about how Medicare, just as an example, and other payers have kind of followed the same thing, have been paying for healthcare up until now. Medicare started fee for service, meaning fee for the individual activity. Go to the doctor, Medicare pays the doctor. Go to the hospital, Medicare pays the doctor. And it started out, as unbelievable as it was, something called usual and customary rates, which meant whatever they charged, that's what the insurance company paid. Right? I mean, there wasn't any system to it. The doctor sent the bill in, the insurance company paid it, minus some, copay or minor deductible. In the late 80s, early 90s, Medicare started doing something called DRGs, diagnostic-related groups. That's for the hospital, basically this kind of service, a hip replacement, heart attack, and some variables in there. The hospital got paid a certain amount. In the early 90s, they put in this thing called resource-based relative value scale schedule for doctors. It was a way to try and analytically think about what is a fair amount to pay doctors, different parts of the country, different services, things. And this Medicare would set the rates, these DRGs and the RBRBS, and other kind of payers would follow, the private sector. And then the annual updates would come out, and then the private payers would respond similarly. As I mentioned, a lot of private payers would say, we'll pay Medicare, we'll pay 120% of Medicare. For maybe they would subdivide it by types of services. In the 90s, into the 2000s, this capitation, just a premium, flat amount of money, like an HMO, became Medicare Part C. That became more refined in the late 90s, early 2000s. Medicare Part D, again, paying a premium, not paying for the individual drugs, buying another insurance benefit just for drugs. Up until about 3 or 4 or 5 years ago, 5 or 6 years ago, now everything's about paying for value. All of this, not really capitation, but Part A, Part B, even really Part D, even though they're buying a benefit. It was paying for individual services. The Part A DRGs is a group of services, everything happens in the hospital, but still paying for a hospitalization. Had nothing to do with what happened to the patient, how well they did they die, did they get the wrong leg cut off, did they go home with the wrong baby. It didn't matter, it just got paid. Value is now, by paying for value, is towards, we're going to pay for an outcome. And I put this in today because I realized I hadn't put it in, but what is value? How do people define value? Well, the simplest thing is quality divided by cost, right? In this thing, you got to figure out what does quality mean, and what are costs? Costs to whom? Right? For the patients, the payer, to society, and then it's value to whom and how is it measured? And that's what I'm going to talk about now, because this is a paradigm shift that's happening as we speak, like a tsunami. Preceding sort of direct value, there's been some incentives, disincentives for just direct quality. Medicare's had a number of programs going back the last 10, 12 years or so, not paying for preventable events or errors like readmissions to the hospital when the person shouldn't be for certain diseases, sort of congestive heart failure, COPD, and I think heart attacks. There's a new Medicare payment system for Part B. Part C is actually increasing. It's been growing up and up and up. It's now about 30%, over 30% of Medicare enrollees are in Medicare Part C, which I consider sort of a form of a quality value-based payment, because Medicare makes these Part C plans meet certain quality measures, and they're now ranking them with stars, so star ratings. You might see some ads starting right around now as they're trying to entice Medicare enrollees. Say, hey, you should sign up with our Medicare Advantage plan. We got 5 stars. We got 4.5 stars. There's probably 1 or 2 that got 4 or 5 stars, I would think. I think the Kaiser one around here has 4 or 5 stars.
I'm a Kaiser member. So.
Did they tell you?
Anybody here belong to an HMO? I've been in an HMO forever. It's a different type of care, but it works.
Well, we talk about the Kaiser plan around here. They bought another HMO that was really having problems, and the first several years, first decade, they had a lot of problems. Now it's quite different. Medicare set explicit goals of policy of value-based payments. 30% by 2016, 50% by 2018, and maybe 80% by 2020. They hit the 30% beginning of the year. They were there. And the other thing is, remember I talked before about Medicare would set the rates and the private sector would respond? Now, complete shift. Medicare is aligned with the private payers and Medicare and Medicaid. They're trying to get as many dollars in this sort of, we're going to pay for outcomes as they can. Because if you're a hospital, you're getting 40% of your dollars from Medicare, right? And they say, oh, we're going to come pay you completely differently. We're going to pay you, based upon how well you do, how well the patients do, all sorts of metrics. You as a hospital administrator, your doctors are going to go, well, that's great, but what do we do for the other, 60% of our patients or 70% of our patients? If Medicare gets the private payers and Medicaid to say, well, we'll do something very similar, so it's all kind of the same metrics and the same concept for how to care for patients, to get paid for outcomes. Now it's 70%, 80%. You can suddenly say, hey, I know how to do this. I can treat all my patients the same, and we completely shift the paradigm. There are certain parts of the country where this is happening pretty dramatically. And it simplifies the lives for the providers. Yeah.
So I don't really understand. So
you're not alone.
The 30%, does that mean that they had some goals, and that 30% of the money that they paid was based on achievement of the goals, or they achieved 30% of their goals?
It's a very good question. I have a chart.
Okay.
Great question. What it means is 30% of the fee-for-service dollars, so not the Medicare Part C, basically Medicare Part A and Part B. We're going to go to providers in ways that they defined as, this is a term we'll come up, alternative payment models, categories 3 and 4. So it's a subset of actually something bigger. This is 2016, linking the fee-for-service payments to quality. And what Medicare defined as value, because it's this buzzword that means so many different things to so many different people, it's ridiculous right now. How Medicare defined it for their payment purposes, these alternative payment models or APMs, meant that there was a variety of factors, but the primary one for our purposes is two-sided risks. So the providers that were getting these payments under these alternative payment models, I'll talk a little more about it, if things went badly, they spent too much money, then they were at risk for getting less money than they would have otherwise. On the other hand, if things go well, they did a good job, they'd get paid more. I put something in here. So, yeah, this is it's two-sided risk, as opposed to one-sided risk, which is also known as shared savings, where like if you did a good job, you got shared in the savings. If things went bad, then you didn't get penalized. That's one-sided risk, and Medicare doesn't consider that really value-based. Yeah, you had a question, Dennis.
How do you define quality? Is it defined by like a patient survey? Is it the bookkeeper saying we met our goals? Is it the doctor saying I had a good outcome?
I think I have a chart. Let me just first talk about this. MACRA is, I can't remember what the heck it stands for, the Medicare Access and Chip Reauthorization Act of 2015, which changed the whole RBRVS system. Well, it kind of did, it kind of didn't. It changed how the doctors were treated under that, and went from the Medicare Improvement System to APMs, ACOs, maybe you guys have heard of that, accountable care organizations, those have been around, and then episodes of care and bundles of care. That these are the kinds of things that qualify under this two-sided risk. But yeah, this is what you were asking about. How do you define quality? Yeah, this is this gets at that a little bit. And I've got an example. I'm going to talk about oncology care model, which is a form. It's getting to be a form of a value-based two-sided risk thing. They just started, but you have to measure the clinical and economic outcomes. As you said, is the bookkeeper saying, man, we used a lot less, billed a lot less, we saved a lot of money, yay, we won? Or is it the patient saying, yay, great care? Or is it clinical measures that say, hey, this person's hemoglobin, the diabetic was down, the congestive heart failure patient now is much more active, they don't have fluid in their lungs, all sorts of different measures for different kinds of diseases. It's all three. It's measuring both clinical and economic outcomes, because if you're just measuring economic outcomes, that's a recipe for rationing. And there's a big Blue Cross Blue Shield plan around here that does something like that, in my opinion. But they're not regulated by the government in this way. Is anybody here from Care First before I go railing on them anymore? No, nobody works for Care First. I have a couple friends that do. But, so the challenge is, though, Dennis, if you want to measure the economic, the book paper says we did good. The patients say we did good. The clinical measures in our medical record, electronic records, say we did good. What's good if, we start with an intervention here, but the trend was like this, or the trend was like this, depending on what measure you're looking at, if this is good or bad. So how do you know out here, did you, if it's just different than this baseline, than a flat line, that doesn't really tell you what you want to know. Did you really do better or not versus trend? And how do you calculate trend in healthcare? Remember all those things that I said that made healthcare so much more complicated than just figuring out, payment on the debt or, Social Security? All of those affect the trend. So that if, I'm going to make this up, but we've got this trend, say, for Medicare spending. And out here, in the middle of this experiment of this model on value-based payments, Congress decides, well, we're now going to pay for, I think it's something ridiculous. Every Medicare beneficiary is now entitled to a Prius, right? So the trend line suddenly is like that. So you got to account for that in figuring out whether the clinicians did better or not. And of course, there's no other colors besides black.
That's all you want.
What's that? You got all this? Just makes it a little hard for you guys to see if I keep scribbling in black. But if in reality somebody starts here, and we'll forget about the Prius, don't worry about that. If this was the trend, and your practice ended up like this, then that's your delta in terms of dollars. Okay, thanks, Greg. For doing that, you need data. You got to model what the future looks like. The other question is, does the payer, some of these hospitals have a lot of money, but a lot of doctors' practices don't. Do you pay them up front to say, hey, we know you're going to need to do things differently, we want to do other services and things. We're going to give you some money up front to help improve the way you're caring for these patients, to make things better, to save more money, to get better outcomes. That adds to the trend. So now this difference, well, you know what I'm saying? So this is the new trend as opposed to this trend back here. You've got to hit underneath.
So you'd be saying spend money for preventive care instead of reactive care.
That's the general concept, and I'll talk about that, yeah. And the other thing is, who gets the savings, right? In Medicare's concept, right, two-sided risk means in their value, it's Medicare saves money, and the payer can get some savings too, and they care about the quality of care for the patients. We talk about quality for whom, value for whom. That's what they're talking about. They really don't care about, is the physician's life that much better? Are they working that much easier? Is there less stress in their lives? That's not part of the quality to value equation. You've also got to worry about random variation. And there's also some discussion about patients sharing in the savings. MedPAC, the Medicare Advisory Commission, talking about if we do some of these things, shouldn't the patients get some savings? One school of thought says healthcare spending slows, so instead of being up here, it's like this. That this difference will then eventually come back to the patients because premiums will be lower, their cost sharing will be lower. That's one way the school thought. The other school thought is, hey, they should get the money directly up front, just like the doctors, in the hospitals and Medicare or the other payers. How do you account for Medicare for random variation? If you've only got 3 doctors in a practice, things can just change. You can get just random variation, so you have to figure out that. In all these ones, usually the payer wants to get their money back first. So it's not just this amount, but maybe the hospitals and doctors will be entitled to a portion. They'll be entitled to this much, but not the part that's down here. The Medicare will get the first part. I don't know if you guys can see that, and then the doctors and hospitals will get the part above that. And also, usually they'll put in a maximum because they don't want somebody to just try and game the system and provide no care and save a whole lot of money and say, hey, woo, we just reaped a huge windfall. So they put called a risk, gain sharing. It's usually gain and risk sharing window, like plus 10 or 15 or 20%. There's also a very interesting concept about differentiating medical risk from insurance risk. Medical risk involves how well the patient was cared for, were things done efficiently, and everything else. Insurance risk is like regular insurance. Concepts of you burn your house down. In the healthcare world, it's things like Zika or a catastrophic flood or other things that the medical healthcare system just couldn't account for. How do you target things towards the greatest needs, the greatest opportunities? The Willie Sutton principle again. Do you just do this for anybody, any place? If you're a policymaker or policy official, where do you want to go to target these alternative payment models to try and save money and improve quality of care? Anybody? Anybody? You want to go up here, right? There's been some great experiments. This guy won a MacArthur Genius Award, Jeff Brenner in Camden, New Jersey. The people up here are typically, a lot of them are really, well, they're all really sick, but they're getting really inefficient care. And by going out and giving them social services and all sorts of other things, and really being intensive about it, you can improve their care, drive costs down, make them much healthier, and it's where you go. Talked about that. This is an example I want to talk about.